Thank you, Alison. That was excellent presentation and excellent cases. It looks to me that treating calcified lesions that are hard to expand are pretty challenging, and that's one of the major risk factors for causing perforation. So maybe we can kick it off by Ivan. I know you've done a lot of work on atherectomy. Is good preparation the secret to preventing such perforations, or what are your thoughts in how to prevent having to go high pressure and rupture the vessel?
Thank you. Yeah, no, I definitely think knowing what you're dealing with is critical. And oftentimes people don't realize how severe the calcium is until they've already attempted a number of devices and have been unsuccessful at achieving adequate expansion. So as you know, I'm a big advocate for frequent intravascular imaging. It'll allow you not just to know whether or not calcium is present, but really characterize the morphology, whether or not it's superficial, deep, circumferential, or nodular. And that's going to help guide you in if a cutting balloon is going to be accurate, the adequate or lithotripsy were available, or atherectomy devices. But I definitely advocate it's good to use upfront lesion preparation rather than reserving it for a bailout.
Great. I know, Bill, you've seen quite a few of these complications. I know you have tremendous experience dealing with them. What are your thoughts? Any things that you want to share with the group based on all your experience on this?
Yeah, I think first and foremost, I mean, Allison, that was a great talk and really well done. A couple of comments is it's not about being lucky. That's not a good plan. What it's about is being thoughtful and having strategies. I think that first of all, if you're going to be an interventional cardiologist, you're going to perfect coronary. If you look at atherectomy devices, it's a 1% risk. If you look overall in PCI, it's a 0.5% risk. In CTOs, it's 3 or 4%. So it may be our most feared complication, but it's also the one we probably ought to spend the most time preparing strategies, preparing ourselves for, and learning how to manage. And so I think the simple things are simple, which is number one, when you deploy a stent or you post-dilate a stent, leave the balloon in the guide when you take your picture or puff, rather than having pulled it all the way out, just to make sure you don't have a hole. That way you can get the balloon back in. It's important to have a perforation kit in your lab, which means like we have a box, and our box has all the covered stents, pericardial drain, the Chiba needle set up so that we can do a more elegant pericardiocentesis, has coils, coil pushers, and microcatheters to put coils. And it's all in one box, in one place, so that if there's a problem in any of our labs, it can be brought in with all the equipment. I think the third piece is practice. So, you need to get practice. You need to run through these scenarios in your head. So I think those would be some of the simple things. And the other is watch a lot of other people's complications, because not all perforations are the same, right? Allison's first case, that perforation is going to have much more profound ischemia because it's collateralizing a large OM. So effectively, when she perfed it, it's like perfing a left main. So not only do you have to deal with the blood coming out, but you have to deal with the ischemia of being up. A lot of times in a CTO, you can leave balloons up for an hour because patients won't get ischemic because they're collateralized from the other side. So I think it's important that all perfs are not the same, and do as much as you can to work with other people or see other perforations so that you get a better sense of the decision trees. Because it's, as Mano said, it's a complicated algorithm, but there are algorithms to think through as to what to do to deal with this difficult situation.
Yeah, thanks, Bill. And I know, Rob, you published a great paper recently on algorithms, not for perforation, but all sort of complications, excellent publication on circuit interventions. Any thoughts on this, adding on Bill's? For large vessel, do you have a preferred cover stem, graft master versus papyrus?
Sure. I think the biggest thing is what Bill said, is just be prepared. You've got to know the algorithms and be ready for that. I think papyrus has been great in terms of being able to get it to places that GraftMaster was a little bit more difficult. But some of the change in the stent and stent delivery system design that has allowed us to get it to more distal or more tortuous segments has also, Bill always talks about every positive comes with a negative sometimes. And because of that negative, because of that positive, there is the negative that it strips more easily. And so we just have to keep that in mind. Yes, we can get it to other places, but it will strip more easily. So I always tell people, you've got to still use a guide extension wherever possible. And just remember, it will come off easily. A lot of us have had the unfortunate experience of dealing with that. And so just be really careful there.
Absolutely. I think before we go on to the next one, any final thoughts from anyone on the panel regarding large vessel perf? Maybe Dan?
Yeah, just one quick comment that it's a low frequency event. So to Bill's point, which is to be prepared and think about it and look at other people's complications. I mean, it really, even in a moderately busy lab, it's, it might be just an event a year, and you've got to be prepared, not just have them on the shelf, make sure that they haven't expired, make sure they're ready to go, and that you've thought about an approach. And I think that's important to reconsider.
Yeah, absolutely. I think we've all had cases where we use the cover stand and then an hour later we have another perforation and we're out of the same size of the cardiac or the cover stand we need. So it's important to have at least two, I think, of each size in the lab.
And another thing, if I can add, Manos, is, for example, if you want to practice coiling, you can practice when you have to, for example, occlude a bypass graft that you use as a rectory conduit in CTO PCI. You can use coil and start practicing that in that occasion with all the tranquility that the situation can afford. So then you're going to be able to use coils more confidently when you really need them to be deployed fast.
So, and
there is one point. Go ahead.
Okay, thanks, Cal. The one other thing I think for everyone to think about too is about phone a friend. So when you have a perforation, it's important to get another operator in the room. But the important piece is not to just get any operator. You need to get an operator, A, that has experience with the technical problem, 2 is a calm head, and 3 is someone who's going to support you because you didn't do a bad thing. You had a bad thing happen. So you want to make sure that there's somebody there who's going to be supportive of you, help you get through this situation, and knows what they're talking about. Sometimes just getting the most senior person in the lab is not the person you want. They may not be a good mentor. They may not be that technically good. They may not actually have that much experience with this. So if you can get to a place, get help, but make sure you get help from the right person.
Yeah, absolutely, Bill. That's a great point. I think everyone will have Dr. Lombardi's phone number at the end, and they can please call him. But I'm sorry, Cal, you want to say something as well?
Yeah, yes, definitely. This stresses the point of if you go into war, you better be armed up for it. So I kind of hate people always liking to miniaturize the guide, and let's use 6 French, even 5 French, and everybody happy about using CSI because you can put it through 6 French. This is when you use an atherectomy, this is the exact things you don't want to do. You want to set yourself up for success from the beginning. Also, you want to expect failures. So if there is a perforation happen, and atherectomy and laser, orbital and rotational atherectomy, they all associated with increased risk of perforation. This is a fact of life, similar to CTO. So I think people should a little bit think before they trying to go with a small guide and trying to do a complex procedure. So I think complex procedure always requires big caliber guides.
Manos, and just to add on Evan's points, I just wanted to highlight your study with Arslan. I think added the important point that the most common mechanism for large perforation was the post-dilatation with the non-compliant balloon after stenting. I think oversizing was shown in a large proportion of cases, so imaging was very helpful.
Absolutely. Good preparation and imaging are important.